Thank you very much, Dr. Khadija, for the kind invitation and introduction. I'm delighted to be here in this gathering of the main umbrella. I've been away from internal medicine for quite some time, but feeling home today in the internal medicine conference. So it gives me great pleasure to be here. So I've been asked to speak on obesity management in general, but obesity nowadays is a science by itself. So we can speak the whole day on causes of obesity, the whole day on how to evaluate a person with obesity, the whole week on how to treat a person with obesity. So I'll try to squeeze that in the coming 20 minutes and try to, as much as possible, go through the obesity management from the age until the last points in how to treat people with obesity. These are my disclosures. I'll be discussing a non-FDA approved medication for obesity, and that's only for academic use. I'm not recommending to use this medication so far until it's FDA approved, and that's the tirzepatide or the Mounjaro. What I'll be doing in the coming 20 minutes, we'll just go quickly through the stats of obesity and what are the clinical implications of being overweight. And then we'll go quickly through the non-surgical modalities of treating those patients. Then we'll finalize it with a couple of take-home messages. I always like to start my presentation with this whenever obesity is concerned. In the 16th century, Leonardo da Pierre da Vinci accomplished this beautiful drawing of an average weight, young or middle-aged pretty lady. But he didn't know at that time that the prevalence of obesity was not as much as of today. So probably by today, if Mona Lisa was being to be established or accomplished, it could have been one of these genes. So that makes my talk a bit of important because the obesity rate, as far as we are concerned, in the Middle East is doubling in the last 2 decades from 16% in average to 34%. And the severe obesity or morbid obesity, that's BMI more than 40, have increased from 2% to 11% in just a couple of decades. And what makes it more scary, that the school-age obesity rates are alarmingly increasing from 11% to 41%, and that's only 25 years difference. So the world map of obesity that tells you that the orange bars are the obesity prevalence, while the blue bars are the overweight and obesity prevalence. And as you can see here, some countries like USA, Kuwait, and Scotland, over 70 to 75% of the population may have either obesity or being overweight. So 3 out of every 4 people roaming around will be having either obesity or overweight. And one of the top 10 countries here, we have the Kuwait, Qatar, and Morocco being one of the top 10, 20 countries in terms of obesity. We did an exercise, and we are so happy to have this amount of data sets. We've gathered almost 450,000 patients, nearly 500,000 individuals who are coming to the Dubai Health Authority, and we're calling this a Dubai Obesity Study, just to mind you that this is unpublished data, so it's just academic sharing until we get it published, then we can take pictures of that. So out of this almost 500,000 population of Dubai, we found that people with BMI more than 25% were 64%. So again, around three plus patients out of every 4 patients might have a BMI more than 25, which is either obesity or overweight. Segregating it into local citizens versus non-local citizens, the UAE population tend to have higher rates of obesity compared to non-UAE population. And
When we take the BMI of more than 30, that's to say the obesity, again, the UAE population tend to have higher rates of obesity compared to the expatriates. What's making it more significant that ages of 40 and above, the prevalence of having BMI of more than 40 is 48% in 40 to 60 years and more than 60 years. So 1 in 2 people roaming around in Emirates of Dubai are having BMI of more than 30. This is quite significant. That's as far as the age more than 40 is concerned. And this is just a simple observation, a cross-sectional study. There is no interference. So that's what makes it more significant. And this will be growing if we don't take any strategic move to stop the obesity from here in a couple of years down the line. So definition of obesity, we all know that it's BMI more than 30, but nowadays definition of obesity is becoming more complicated as per the Obesity Medicine Association, that obesity is a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease wherein an increase in body fat promotes adverse metabolic, biomechanical, psychosocial, and health consequences. So it's not only simply the BMI of more than 30. Just to remind you with the different classifications of obesity, and if we take the BMI as the foundation of that, if BMI is less than 25, this is normal. Being overweight, 25 to 30, 30 to 40 is stage 1 and stage 2 obesity. More than 40 is either extreme obesity, severe obesity, morbid obesity, and you can name it at different names. So this is a BMI system we've just mentioned, and some other societies are adopting what's called the Edmonton obesity staging system. For the sake of the time, we'll just highlight that there are different ways of staging the obesity. What causes obesity? We always blame patients that you don't move, you eat a lot, you don't exercise, so that's why you are having this BMI of more than. But this, all what I've mentioned is just these 2 points, and we tend to forget all the rest of the things, that there is a physiological causes of obesity, there are other possible genetic backgrounds of being obese, then environmental causes, which is the cardinal cause of obesity, and this is always being ignored. So speaking with a patient with obesity, we have to get to the roots of why he is obese, and then to try to sort this out as the time goes. So it should always be a blame-free environment between the treating physician or any healthcare provider and the patient. We should not blame them why they are overweight or obese. We all know that obesity is well related with so many cardiovascular, metabolic, mechanical complications and vascular complications, including diabetes, hypertension, dyslipidemia, cardiovascular disease, and whatnot. So this is a very old data, but that was the first highlights that linked obesity with cardiovascular disease. It's called the NURSE study. Over 40,000 healthy nurses in France and other European countries, and that it demonstrated that just having a higher waist circumference increases the risk of coronary heart disease as the time goes. And those ladies were middle-aged, healthy, and that was after adjustment of BMI and other cardiovascular risk factors. So just having higher waist circumference increases the risk of coronary heart disease as the time goes. So is obesity a disease? The stakeholders and the strategic planners, they take it with a pinch of salt that obesity is not a disease. Obesity is something that the patient himself needs to take action to guard against it. But that's not the agreement from different societies. Now, obesity is well recognized as a disease from FDA, ACE, the American Medical Association, the Obesity Society, WHO, European Association of Study of Diabetes, and whatnot. So those are just examples of different societies and associations that considered obesity is a true, proper chronic medical disease that needs proper attention. Obesity is not always something that just took place in the last 1 or 2 or 5 years. Almost 75% of patients in this survey from Canada stated that they did have this obesity issue for the last 10 years. 30% of those patients, they stated that they had the obesity for their entire life. So it is a very much chronic disease that started at a very early age and continues. Then we need to take an action to stop this vicious cycle. 25% of those patients, they said, we stopped counting how much we tried to lose weight. And some of them, they said, we tried that more than 20 times. And this zigzag, we know that it makes weight loss even more difficult as the time goes, because when we lose weight, we lose both fat and lean body mass. And when we regain that weight, we regain only fat mass, and fat mass is more difficult to work on it as the time goes. So when we have a diet, we lose weight and then we regain it, then again diet, we lose weight and regain it. Things will be more difficult as the time goes. So zigzag weight loss and gain should be avoided, and that should be by the strategic planning of how to treat people with obesity. How to revert Mona Lisa back. So let's agree, and this has to be agreed upon between the treating physician and the person with obesity, that losing only 5 to 10% might improve the risk of progression to diabetes. And sometimes now we have the data that the diabetes could be reversed to pre-diabetes state by just losing weight, reducing cardiovascular mortality, reducing blood pressure and cholesterol, and improvement of obstructive sleep apnea, and so on. So just simply 5 to 10 kilograms weight reduction matters. So here we go. How to treat people with obesity. It's a very long discussion that I have to tackle it in the coming 10 minutes, but just quick survey or surveillance will be through the pillars of managing people with obesity should include most of these. Should include nutrition advice. The patient should adopt a regular and proper physical exercise program. We need to go deep inside the brain of this gentleman or lady and work on the behavioral background of why he is obese and how to treat that. And then we may need to go for pharmacotherapy or sometimes to bariatric surgery. This is a journey of how we set the plan between us, the healthcare providers, and the patient. From the start, now most of our patients, they do come and complain about obesity, but sometimes we tend to see a patient with joint pain, and he is obese, but he never speaks about his obesity. So the first opening question would you mind we speak about the weight and how to deal with it? I'm sure most of them will be happy to take this conversation forward, but if the patient doesn't want, we need to know why he doesn't want to proceed in how to treat this obesity. But this should be the opening question. And if this, in case the patient did not come up with the obesity complaint from the first place, then we need to assess why this gentleman or lady is obese and tackle the different underlying causes of obesity. And we need to tell the patient that for now, we have different ways of treating this condition, either the lifestyle modification, pharmacotherapy, and even surgical intervention. Then we need to set realistic goals. Someone with BMI of 45, I cannot tell him that just do lifestyle modification. Next 6 months or a year, you will be with a BMI of 38 or 35. This is not a realistic goal at all, and the patient will lose faith in you. So you need to tell him that the lifestyle modification a proper lifestyle modification would reduce the weight by somewhere between 4 to 8% at max. So we have to set realistic goals and agree on it between us, the healthcare providers, and the patient. So I found this sculpture in Dubai Mall. So if we want to speak about the physical lifestyle, is anything other than what this gentleman is doing. So we need to maintain a regular weekly walk, or at least, or any exercise for more than 150 minutes. And a better results will be attained when we attain exercise of more than 300 minutes per week. This exercise could be only brisk walking, any sports of interest, even dancing would do the job. And we have, at least for those senior citizens or those who cannot apply this intense physical exercise, what's called the lower thermogenesis physical activities. That should be something like the gardening, walking stairs, even slowly, it's fine, doing the home chores. And but this, we need also to tell the patient this is 50% less effective than the strenuous lifestyle modification or exercise. And to help the patients as much as possible, if they can use the apps, not the technology, to help them going through that. I think Netflix should pay us for this. This is a strategy that I tell most of my patients who are coming to me with obesity. I call it Netflix exercise. I just ask them every day, instead of going to the gym, losing 30 minutes before going to the gym, losing 30 minutes coming back from there, wearing different costume to go to the gym, just try to get a treadmill, cycle, do any exercise while watching one episode of Netflix every day. You will not be bored with the exercise. You will not even watch keep watching the timer that the 30 minutes is over or not. And with time, it will become a habitual way of doing it. And believe me, it does work. It does work. I go even a mile further. I suggest the series for them. I ask him, what sort of series do you like? History, action, romance. I'm a cinema addict, unfortunately, but I have the full list, and even suggest and write it in a piece of paper. This is 4 seasons, around 300 episodes. This will take us for almost 5-6 months. And believe me, it does work. All what we need is just to make the exercise part of our daily activity. It's not. We were not raised to have the daily activity and exercise in our community. So it could be a way. Just please try it and pray for me if it succeeded. Okay, nutritional advice to the patients. I'm not really the right person to speak on that. We need a clinical nutritionist to dive with us deeper in this, but we have loads of different nutritional protocols: Mediterranean diet, low caloric diet, and very low caloric diet, low fat, or the Ornish protocol, ketogenic diet, intermittent fasting, and DASH. And I take myself as a candidate for this. I lost 13% of my body weight using this intermittent diet at some point in my time. Only intermittent fasting. I don't even do this Netflix exercise. 13% of my total body weight, and I have maintained that for a couple of years so far. So it does work. And lifestyle modification matters not only in reducing the weight by 4 to 8%, it does even reduce the micro and macrovascular complications. This is the time frame in the coming 2 minutes, just quickly, that we have the lifestyle modification, which might reduce the weight by 8%. Pharmacological therapy now might go and reduce the weight by 25%. And and the surgical parameters, like the bariatric surgery, sleeve gastrectomy, 25% of body weight, and more than 30% with a gastric bypass. Those are the options of medical treatment that we have, either oral or injectable. This is a long story, but in UAE, we have the Orlistat, we have the Contrave, which is the naltrexone and bupropion. We have the Saxenda and the semaglutide, or the Ozempic. Actually, the semaglutide 2.4 is Wegovy. We don't have it here yet, but people are using the semaglutide off-label. And nowadays we have the new kid in the block, the tirzepatide or the Mounjaro. Liraglutide in a scale program have shown that almost 60% of patients did lose at least 5% of their body weight, and around just 5% of people did lose more than 20% of their body weight in 6 months. While the semaglutide, which is the second generation of the weekly GLP-1 agonist, around 30% of those patients did lose more than 20% of their body weight. And now everybody was waiting for this. What about Mounjaro? Mounjaro is the new, this is the last slide before the conclusions. The new kid in the block that managed to reduce somewhere around 25% of body weight, and majority of patients, almost 40%, did lose more than 25% of their body weight in high dose, the tirzepatide or Mounjaro. This is better than gastric banding and comparable to the gastric bypass. And just to remind you that obesity is a chronic disease. Whenever we stop the medical treatment, then we might get or have a rebound of obesity afterwards. So the last slide was the take-home message, and I think we can discuss that in the Q&A session or in the corridor. Thank you very much.